Okay, so uh, good evening, or I would say good afternoon, everyone. Uh, we're going to talk about mainly renal trauma, or you can say like the traumatic renal complication or complications. So it's not quite often we see this traumatic, I would say, renal complications or renal injuries because a lot of times uh, few of the things happens in the way that you might have a direct renal injury because of the trauma or high moving velocity, but a lot of time it is secondary. So we have to be constantly kind of taking care of the kidneys when we are thinking about any traumatic patient, just not because there could be a direct trauma, but there could be an indirect trauma to the kidneys because of multiple things that might be related, like you can say myoglobin urea, you can say the child might, or the adult or child might be on a lot of medications which can cause renal injury. Then you have a shock, you have an infection, you have a hemorrhagic shock. All those things also causes the higher chances of renal complications. So remember, as I told you, the kidneys might be involved primarily. So what do you mean by primarily means? That you can have a direct injury to the kidneys. Most of, if you see the literature, most of the renal injuries are primary. Primary means there is a direct injury to the kidneys. The renal injuries might ranges from, you can say, the direct injuries to the pelvis or direct injuries to the urethras, urinary bladder, whenever it's full, or it could be a direct kidney injuries where actually there might be a laceration of the kidney, which can give rise to the lot of other complication over the time. So kidney injury is most commonly injured if you think about high moving velocity or traumatic injuries mainly related to the roadside accidents. So 3 to 5% of the trauma patients you see. So most commonly injured is the kidney, and of overall trauma patients, you can see 3 to 5% have kidney injuries. 80 to 90% concomitant injuries, in the sense it's not an isolated injury. You can have involvement of the other systems also. And one of the system which is going to give rise to a complicated issues might be a kidney. So remember, isolated kidney injury is very rare. Most of the time it is associated with, I would say, concomitant injury, which might be related to the other organs, and it is most commonly injured, but the velocity or probably the intensity of injury changes according to the nature of a trauma. And as we discussed, the most common is the blood injury. So blood trauma over the abdomen, it might be related to the high velocity injury. It might be related to the seat belt injury, where there is a acceleration and deacceleration, which can give rise to the kidney injury. So what is the difference between the pediatric and adult injuries? You can see most of the adult renal injuries are accidents and high velocity injuries, and second being falls. So very unlikely the adults will fall, and because they have a lot of protective mechanism to prevent injury to the vital organs. They might put their hands down, or they might handle their position such a way that it's not causing injury to their vital organs. But it doesn't happen in a pediatrics population. Most of the pediatric renal injuries are unanticipated falls. So they just fell down and they were not able to take care of themselves, and they had a bad injury over the abdomen, which might include the liver, intestine, and sometimes kidneys. And as I told you, acceleration and deacceleration injury, which is mainly related to the seat belt injury. So there are a few reasons that there is no appropriate kind of a seat belt for the pediatric age group. So they are not fitted comfortably in the seat belt. So whenever there is a sudden break, there is an acceleration and a deacceleration of the viscera with respect to the speeds, which causes tear injuries in the organs, which are actually linked with some, I would say, uh, ligaments or fascia. So these organs, they move ahead and they can cause a lot of other injuries. It might be related to the vascular pedicle or parenchymal injuries. So what kind of a renal injury classification we see? So there are few other classification, but this is widely accepted renal injury classification, which is given by American Association for the Surgery of Trauma. So what are those? You can see grade 1, grade 2, grade 3, grade 4, and grade 5. So grade 1, So most common injuries are in the region. So this is the percentage of a patient who are having a grade injuries. So grade 1 and grade 2 common are almost most common renal injuries. Then grade 1, grade 2, grade 3 share the same percentage of, I would say, occurrence. Then stage 4 is little bit low and the stage 5 is very less. Each is divided into two. Most of the time, the types of the injury decides about this grade of classification. So you have contusion, you have hematoma, laceration, and vascular. So these are the four things which you have to keep it in the mind: contusion, hematoma, laceration, and vascular injuries. So let's talk about grade 1. What happens in a grade 1? You can see the pictorial diagram here also. There is a microscopic or a gross hematuria. As I told you in the beginning, that not every renal injury needs some kind of a contusion or some kind of a visible contusion or on the ultrasound or in a CT scan. You can just have microscopic or gross hematuria. So here there is a contusion of the kidneys, and what you have is microscopic and a gross hematuria. Most of the urological studies will be normal. So this is basically unnoticed or probably associated with other organ involvement. Then you have a hematoma. Most of the time it is a subcapsular hematoma. It's non-expanding without parenchymal laceration. So there is no parenchymal involvement and there is a subcapsular non-expanding hematoma. Then you have a grade 2 injury. What happens in a grade 2? Again, you have a hematoma and lacerations. So hematoma, which is there, it is non-expanding perirenal hematoma confined to the renal retroperitoneum. So there is a hematoma around the kidneys, not inside the kidney. So first was subcapsular. Then you have a second where there is a hematoma which is non-expanding around the kidneys. Laceration. So laceration in the stage 2 is less than 1 centimeter parenchymal depth of the renal cortex. So and there is no urinary extravasation. So what things we see here? Stage 2, you have a hematoma and laceration. Hematoma is around perirenal space and it involves the retroperitoneum, and laceration when it is less than 1 centimeter. Then stage 3, what happens in a stage 3 is you have a frank laceration, so more than 1 centimeter of the parenchymal, but the collecting system remains okay. Then you have a stage 4. What happens in a stage 4 injury or a grade 4 injury is laceration. So you have a parenchymal laceration which includes renal cortex, medulla, and collecting system. So it's going kind of a through and through, you can say. And the stage where you can have a vascular injury also in the form of main renal artery or renal vein with contained hemorrhage. So there is an injury to the renal artery and renal vein, and there is a contained hemorrhages. And the grade 5 where you have a completely shattered kidney and devascularized kidney. So how do you keep it in the mind? Stage 1, microscopic hematuria and small subcapsular hemorrhage. Stage 2, you have a less than 1 centimeter laceration. Grade 3, more than 1 centimeter laceration. Stage 4, where you involve the complete parenchyma but kidneys are not shattered and there is an injury to the artery and vein, but it's a contained injury. And stage 4 is a complete shattered kidney and devascularized kidney. So there is a World Society for the Emergency Surgeries which had a kidney trauma classification, and there is an American Association of Surgery of Trauma classification. So they have also given few grades. So you have minor, moderate, and severe. So when we consider the kidney injury is minor or moderate or severe, when we are counseling the parents or when we are telling, so minor, which is grade 1 and grade 1 and grade 2 and ASAT. What do you mean by that? So that means that you just have a microscopic hematuria, small kind of a, I would say, small hematoma, subcapsular hematoma, or less than 1 centimeter of laceration. And there is hemodynamics is stable. What happens in a moderate? Then you have grade 3 or segmental vascular injuries. That means the laceration is more than 1 centimeter. You started having a renal artery or renal vein injuries, and there is no injury to the cortex, or there is no complete shattered kidney. And this is called as a West grade 2. Severe, what happens in a severe? So you have stage 4 and stage 5 where there is a complete parenchymal injury to the renal artery, renal vein, as well as there is a complete devascularization of the kidneys as well as shattered kidney. So most of the time hemodynamics is stable. But in a West grade 4, which is depend upon the clinical stable, any of the injury which is associated with unstable hemodynamics is called as a stage 4. So remember, What is the type of an injury is definitely important, but at the same point of time, if the clinically child is stable, probably they have really manageable issues. But if they are unstable or bleeding extravagantly, so they can have an unstable hemodynamics and can result in very severe grade of a renal injury, depending upon, irrespective of the degree of injury. So, what should be our approach when the child comes to emergency for, I would say, polytrauma? Most of the time, this kids present as a polytrauma. So, we should ask in detail about history. So, what history stands for? Most of the time, they come to the emergency, and then we should ask about the mechanism of injury. The reason for asking the mechanism of injury is we'll come to know what kind of an injury we should expect when we are talking about the kidney injuries. So, mechanism of injury, as we talked about, a seat belt injury or high motor velocity injury, these are all are very important. Then you have a previous renal issues. That means there is a chances that some child might be having some chronic related kidney related issues, or it could be a PUJ, or it could be VUR. All those things are important because once the injury set in, it is very difficult to identify which is causing the symptoms, or probably which is making the system difficult. So you should ask about the previous renal issues. You should ask about the medication. Is the child is on any medication? Sometimes these kids don't present immediately. They go to the peripheral center where they don't recognize the renal injuries. And these are the kids who receive a lot of medications. That medication itself can be nephrotoxic. So this is also another very important thing, because as we see, we don't have to have exactly, I would say, CT changes to call it a traumatic renal injury. Then you should ask really about bleeding per urethra, or whether the child is able to pass urine or not. There is a hematuria or a visible trauma, or you can see blood at the meatus. All those things are very important to understand what kind of an injury you are dealing with. And as we know that 80 to 90% of the time renal injuries are associated with other organ injury. So we need to find out the reason for the other organ injury. Sometimes the renal injury cannot be primary. It can be secondary. What do you mean by secondary means that there is an reason for secondary injury with respect to the treatment of a primary injury. That means nephrotoxic drugs, myoglobin urea, thromboembolism, all those things. So, what do you see in examination? So, as we discussed, the most important thing in this case is to identify whether they are stable or unstable. Because whatever the grade of an injury, if they have unstable hemodynamics, it makes the degree of injury very severe. And other things which is important simultaneously when we are checking for is anemia, okay, any bleeding from other sides, okay, other organ injury. Is there any mass or hemoperitoneum we are seeing? Is the child is catheterized if the child is coming late, or there would be a pain in the suprapubic region, because it can be associated with bladder injuries also. What investigation? So once we understood what kind of an history we are dealing with, what kind of an injury we are dealing with, what we are expecting, and our examination is actually pointing out towards some kind of a renal injuries, you try to identify or you try to strengthen your diagnosis by doing some investigation. So what are the investigations which are very important? So when we talk about renal injuries, the investigation which are very important is definitely urine analysis, because in the stage one what we saw, or degree one what we saw is even microscopic or gross hematuria can be the clinical presenting symptoms. Basic investigation. So what investigation we should think about? Definitely CBP. We should think about PDFDT, INR, because these are the kids might require some intervention. We should think about coagulation parameters, platelet count. Okay, and these kids can have a metabolic acidosis. So we should think about blood gas and sometimes blood grouping and cross matching. The reason for blood grouping and cross matching is these kids might require the urgent, if the child's are hemodynamically stable and over the time they become unstable, they might require the surgical intervention. So know the impact of renal injuries with respect to the function. We need electrolytes and renal function tests to show what is exactly happening, and radiological investigation, which is going to strengthen our diagnosis. So this is the one which is going to tell us which kind of a grade we are dealing with, depending upon the vascular injuries, depending upon the parenchymal injury. Another question comes in this radiological investigation. Shall we go ahead and do the contrast? So try your best to prevent the contrast, because you don't know and you might land up into the frank renal injury, and the contrast itself may cause some renal injury. So it is very prudent to not use contrast, and it should be used when it is extremely necessary or you're dealing with that, you definitely going to require the surgery for or a reimplantation of the blood vessels. So radiological interaction. So as we see, we should avoid, but when we really are worried about the kidneys and the vascular injury, we should do a CT with the contrast. So it is seen and read in the 4 phases. So one is pre-contrast, what we see, whether we are able to identify hematoma or injury or I would say densities as respect to the CT scan around the kidney areas, other organ injuries. Then we have a post-contrast arterial phase, which lasts for around 30 to 40 seconds, where we see the arterial integrity. Then we have a post-contrast nephrogenic phase, so where we see the functioning or probably the ecotexture, or probably, I would not say ecotexture, but probably parenchyma of the kidney. Then we have a delayed phase where we actually try to evaluate the veins and we try to evaluate the collecting system and the excretory system of the kidneys to know whether there is an injury. So how do you come to know that? So we come to know that there is a leakage of a contrast, or probably there is a pulling of a contrast around the vessels or around the, I would say, ureter, where it says that there is a possible region of an injury and trauma and extravasation. So what about the intravenous pyelography? So it is less effective as CT scan because again, you have to be really dependent on the excretory function of the kidneys to take care or draw any conclusion from this investigation. Ultrasound abdomen, a lot of times we do a CT scan, but we follow this patient based upon the ultrasound, regularly ultrasound. So what we see is we try to identify in the abdomen either we are dealing with urine or blood. So how to differentiate between the two? So urine is kind of a less ecogenic in the initial phase, but over the time urine can actually cause some inflammation and can becomes more ecogenic. But blood is definitely ecogenic and get coagulated easily, and you might see a little bit of fibrin stand and septation. Vascular pedicular injuries, what you can see is there is a loss of, I would say, velocities into the particular areas. You might not see the flow, or the velocities are very less, or it could be an obstruction also. Segmental infarct, you will see a vascularized zone in the kidneys, which you can see most of the time is kind of a wedge shape. And ultrasound abdomen is also very helpful in follow-up. As we saw, once we diagnose through the CT scan, we can follow this patient to know what is an extent of the bleed, what is an extent of the particular injury, it is worsening or not, whether the infarct is worsening or not, and at the same time for the improvement. So, so when we should think about kidneys, and what are the kind of, I would say, procedure we should think about or investigation we think about when we are diagnosing the kidney injury. So one thing is hemodynamic status. So how the hemodynamic status helps. So if we have a tentative or probably a history suggestive of high velocity injuries, and we have a bad hemodynamic status, we should always think about visceral injuries. And one of the very common organ involved is kidney, as we saw 80 to 90%. So identifying the kidney injury through the EFAST. So we know that EFAST is for the major things like a major bleed. But for the low, identifying the degree of injuries or to identifying exactly what kind of an intervention we should try, EFAST has a low sensitivity to diagnose the kidney injury. Contrast CT with the delayed contrast CT with the delayed contrast excision is a gold standard, and we should always try to get it. But has to be done in hemodynamically stable patient. It is unavailability to do this scan in a patient who is hemodynamically unstable, because you know that they can have a kidney injury, and if they are hemodynamically unstable, you can induce the more kidney injury because of the contrast. And you can really go ahead with this kind of things irrespective of the blood pressure in hematuria. So contrast CT is definitely warranted, and make it sure that the patient is hemodynamically stable. But if you are not able to make the blood pressure stable and you are suspecting the renal injury very strong, you can definitely go ahead and do this test when you have a strong suspicion of a renal injury. When we should trigger ourselves in pediatric population, any hematuria, you should go ahead and have a diagnostic kidney diagnostic procedure. High velocity injury, always rule out. In my unit, in a high velocity injury, I definitely rule out two injuries. One is cardiac and second is kidney. There is a significant drop in the hemoglobin and you are not expecting any injury to the liver or spleen. And No imaging. So you can reasonably say that I am not going to do any imaging in this kind of a patients, or I don't want to do any imaging when we are suspecting some trauma. If the child is clinically stable, there are no symptoms, and there is a very less microscopic hematuria, then you can reasonably manage them clinically through the ultrasound without doing the CT scan. So this is a algorithm for kidney trauma. What you can see, when you suspect a kidney trauma, what you see in the emergency department, what you do, you should try EFAST. What is an EFAST? Definitely we try to identify bleeding around the spleen, bleeding around the liver, kidneys and bladder. So you can try thoracics, depending upon the injury to the thorax, what we called as a EFAST, and pelvic X-ray. So kidney trauma, if you are hemodynamically stable and you are suspecting the kidney trauma, contrast enhanced CT scan with delayed phase has to be done. Then you can identify minor lesion, moderate lesion, severe lesion, or evaluate urological lesion. So mainly you will try to identify these three things, and ultimately you can consider angio if required, and you can try angioembolization if there is a vascular injury. And if you are able to effectively angioembolize them, and subsequently in the follow-up, child is clinically stable, everything is fine, so there is no indication for laparotomy. So you can go ahead and manage it without that. Good. So this is about when you are hemodynamically stable and you are able to do the contrast CT scan with delayed phase. One thing what happens is during the delayed phase, you evaluate the urological lesions also. If you think that that is the reason, because if you have a urological lesion, there is a more and more chance that you might have required the laparotomy, or probably you have to do through the laparoscopic surgery. And in this season also, if there is a mild, moderate, and severe lesion, and the angioembolization doesn't work, and the child consistent to have hemorrhage, and things are not improving, then still also you have to open the abdomen, go for laparotomy. Or sometimes there might be other reasons to go ahead with the laparotomy rather than the kidney itself. During that time also, you can inspect the kidney and see whether the things are functioning fine or not. But if you are hemodynamically unstable, what do you do? So you can, the ideal setting what you have, you should have a setting where actually you can do both radiological intervention, and if it doesn't help, you can directly go for a laparotomy. So in that room, if you are able to achieve the effective endovascular management with respect to the blood vessels, then you wait and watch. But if it is not, so you know that hemodynamically unstable is a stage 4, because there is a hemodynamic instability, whatever the type grade of a lesion. So then you have to straight away go in the laparotomy and salvage the kidney as much as possible. So how to approach? So you have a child with the kidney trauma, you do the basic things. So you put a cannula, give fluids, probably arrange for the blood transfusion, evaluate for the other organ injury, and simultaneously you get a EFAST done. In a EFAST, while you are doing a EFAST, you might have a two situation. The child is hemodynamically stable, hemodynamically unstable. Hemodynamically stable means either we are dealing with minor, moderate, and severe lesion without hemodynamic instability. Here, what you can do, you can see depending on if there is a gross injury to the collecting system, go for a surgery. If there is no and there is a bleeding happening, then what you do? You do for an angio. And if the angio is effective, wait and watch, no laparotomy. If the angio is ineffective, then go ahead, and the hemorrhage is persisting, go ahead for the laparotomy. Hemodynamically unstable, you try the intervention in the hybrid room where there is a intervention as well as surgical option available. If everything goes fine with the effective endovascular management, continue normal management. If it is not, then you go ahead with and open the abdomen. What about ureteric injuries? So ureteric injuries, these are also again high intensity injury, as I told you, acceleration and deacceleration injuries. Sometimes it could be penetrating injuries. So here, most of the things you'll be able to identify after CT contrast with the delays phase, as we discussed, it's a gold standard. And examination during the laparotomy itself is very helpful in a suspected injury cases. So here we have to most of the time go ahead and repair it, because there might be a constant leak of a urinary urine inside the peritoneum, it can cause the peritonitis. So again, ureteric injuries, high intensity injuries, you should suspect, you should have a high index of suspicion. Okay, when the child is going for any of the surgeries related to the high velocity injury, you go and inspect the ureter, and you can do a CT contrast with the delayed excision. Bladder injuries. So for a bladder injuries, how do you identify? Most of the time, you can see there is a classification related to the bladder injuries. Again, given by American Association of the Surgery for Trauma. Grade 1, there is a contusion. Grade 2, there is an intraperitoneal bladder wall laceration. So there is a leakage of a urine. Then you have an interstitial injuries, and then you have extra peritoneal bladder wall laceration. So about the peritoneum, it could be simple or complicated, and then you have a 5 combination of injuries into intraperitoneal, extraperitoneal. So it all depends upon what kind of injury you are talking about to the bladder, whether it's intraperitoneal, extraperitoneal. Remember, extraperitoneal is bad as compared to the intraperitoneal. What you can do to identify is you can do retrograde cystography if it is the facilities are available. Angioembolization cytography should be avoided, and examination during the laparotomy. Remember, when you are suspecting the lower urinary things injuries like ureter, urinary bladder, urethra, it is prudent to check for them when you are going ahead with the surgery. It might be related to the other organ, or it might be related to the kidneys. Urethral injuries. So urethra, most of the time urethral injuries, you can have urethral hemorrhage. You can see a blood at the tip. You can do a urethrography, urethroscopy to identify the urethral injuries. Again, here the acceleration, deacceleration injuries are common. Other thing is direct injuries, which is very, very important when you're talking about the urethral injuries. In a penile injury, if you have a penile injuries with urethral injuries, urethroscopy is preferred modality of investigation as compared to the other things. There are different types of injuries we see depending upon the level of injury and grade of an injury, which all depends upon the presence. Remember, there might be a complete transection which might lead to the very, very severe grade of an injury, what you can see in this here. So for urological lesions, how do we see? So again, urological lesions also you see whether the kids are hemodynamically stable or unstable. Then you have these things involved. So you have hemodynamically stable or stabilized patient. Pre-operatively, you have diagnosed that there is a ureter, bladder or urethral injuries. You proceed. So how do you proceed? So there is a pre-operatively diagnosed ureter, renal pelvis, ureter, renal pelvis. Okay, contusion, hematoma. You can put a urinary catheter, put a stent, and wait and watch. Sometimes you might require dissection and nephrostomy. There could be a complete avulsion where nephrostomy, stent, and surgical repair is required. So, depending upon the type of injury and the nature of injury, you do your call when the child is hemodynamically stable. About the bladder, you can again have a contusion, you can have extraperitoneal, intraperitoneal injury. But if it is a rupture, what you do? If it is an intraperitoneal, you do the surgical repair and put a urinary catheter and a drain. But if it is extraperitoneal repair, urinary catheter is non-complicated lesion. Consider repair it. Okay. Then you have urethral lesion. Sorry. Urethra. So you can have anterior and posterior segment. Anterior segment you can have penetrating or blunt injury. So remember, if you have a penetrating urethral injury, you have to go for an immediate surgical repair, and it requires a lot of skills. But if it is a blunt or posterior, you can see and try endoscopic realignment to have the avoid, probably I would say, fibrosis and a stricture of the urethra. But if it is not working, then again you have to go for a surgery. When you are hemodynamically unstable, most of the time you might see a bladder and ureteric pelvis injury and sometimes urethra. So remember, the approach remains the same. If it is a bladder, if it is rupture, intraperitoneal, extraperitoneal, depending upon the rupture, you go ahead and do the treatment as a surgical repair or catheter. Ureteric renal pelvis injury, what you do? Same thing here. If it is a contusion and hematoma, you try to put a urinary catheter and a stent. And if it is a complete avulsion, depending upon the lesion, where is the lesion, you try to put a stent and do a nephrostomy. So what about, there is another approach which is given by the European for ureteric injuries. So first of the time, we don't see the ureteric injury immediately. So if you are getting diagnosed immediately, If they are stable, go for the immediate reserve. If they are hemodynamically unstable, okay, so just go ahead and do a damage control nephrostomy, bypass the urine flow, and wait and watch. Follow up. And the follow up, if there is a stricture, yes, then you'll go for a surgical end-to-end ureterocystostomy. You can try endourololigation also, dilatation also. But if there is a delayed diagnosis and nephrostomy digestion can be done, follow up. If there is a stricture, again same thing we follow stricture. We try to operate depending upon the, if it is upper one third end-to-end anastomosis, again mid one third end-to-end anastomosis, lower one third. Okay, they do a sausage long segment depending upon the amount, the length involved. They go for a graft, uretroplasty, intestinal transposition, all those things. But most of the time, you can see 50% of the time, end-to-end anastomosis works well. So, what is a non-operating management? You usually try that thing when they are hemodynamically stable. You have the 24/7 AOT available where you can take the child at any point of time and operate if time required. Classification is very important when you are dealing or when you are choosing non-operating management. That means you can't just go and do non-operating things for a child who's having a hemodynamic instability and grade 2, grade 3 injury. So make it sure that you are classifying importantly and paying a good attention to the hemodynamic status. Remember, penetrating renal injuries, be careful. So don't try to delay the surgical things in a penetrating injuries because they might be really tricky. And you try some non-operating management when you have a low resource setting where there is nothing available, so that you just have to try to save the patient with non-operating management. So again, what we talked about kidney trauma, remember these things are very important. So it's a joint effect between, depending upon the hemodynamic status, stable or unstable, it's a joint, in a experience setting, it is a joint venture between, I would say, um, intervention radiologist, urologist, and surgical team. Because it involves a lot of things. A lot of times you can have a vascular injury which can be saved with just angioembolization, and you don't have to go for a surgery because most of these surgeries are hot and you don't know what you land up in removing when you go for a surgery in this kind of a patient. They can have a splenic injury, liver injuries, and you can make the things more worse by going in rather than not going in. So when you talked about the primary lung injury, which are directly related to the trauma, there are secondary renal injuries. So what are those? So secondary renal injuries, what do you mean by that is, it could be a functional. That means the hematoma has happened, trauma has happened, but the kidneys are not functioning well. There might be an accumulation of urea, creatinine, there might be a hyperkalemia, metabolic acidosis. So it might be related to the primary renal injury, or it might be related to the other organ injury, which is actually complicated by the kidney injury. It could be systemic inflammatory response syndrome, sepsis related acute kidney injury, and a lot of times they have a lot of muscle injury which can give rise to the myoglobinuria, which can damage the kidney by itself. So a brief about myoglobinuria. So mainly you deal with the when you deal with the bad crush injuries, the lot of myoglobin is circulated into the system, which itself give rise to this myoglobin, and the kidneys are not trained to take care of a myoglobin, and then you started having the what you call as a pigmentary nephropathy or acute tubular necrosis, or sometimes parenchymal also injury. So here high index of suspicion is very important. A lot of times you'll start getting cola or brown color urine, and it is very difficult to differentiate between myoglobinuria and hemoglobinuria. But if you have a crush injury, the chances of myoglobinuria is more than the hemoglobinuria. And we think about that once the RFT is deranged, that means the renal injuries happened. No, there are a lot of things happens even before the RFT start deteriorating. So there is a fall in the urine output, mild metabolic acidosis, slowly positive balance will build up. So don't wait for the RFT to derange to diagnose the myoglobinuria. Management. So most of the time, remember that the myoglobinuria, we have to protect the kidney. So we have to hyperhydrate so that the myoglobin crystals are not getting segmented into the kidneys. Alkalization, so how alkalization helps? It improves the solubility of myoglobin. You try intermittent Lasix to keep the urine output more than 2 ml per kilo per hour, and try to do the debridement. Whatever the crush injuries you have, go ahead and remove that bad tissue so that it's not no more a kind of a feeder for the myoglobin. And lot of times, actually, this patient, once they set up into the acute renal injury or established renal injury, they require a CRRT because Myoglobin is very difficult to get from the kidney. Thank you.
Thank you, boss, for in detail protocol based and flowchart based management. I think many of us will be using these slides. And like you have mentioned, these injuries are not very common in pediatric, but when they are seen, they need to be managed in a very aggressive manner, and also should understand how to take care of extra solute load. So one question is there on message regarding in renal, the solute load with cerebral salt wasting versus SIADH being seen in a trauma patient. So when we manage such patient, dyslipidemia is there. How do we differentiate between these two? Basically, it's a neurotrauma based question, but asked here.
Okay, so SIDH and what you said, SIDH and
Salt wasting.
cerebral
See,
salt wasting. So it's, I would not say it's very simple, but SIDH is basically your total body water is more or normal, and your sodium is on the lower side. And cerebral salt wasting is basically you are pouring out a lot of salt through the urine, and most of the time they are dehydrated. So this is a gross difference between the two. And remember, in SIDH, the urine output will be on the lower side, and cerebral salt wasting, the urine output will be on the higher side.
there is no other question. So with that, I think we will conclude the session. And thanks again, boss, for giving time. Hope to see you soon. Fine. Thank you. Take care, boss.
Yes.